So we know how the menstrual cycle regulates, what is the role of estrogen and progesterone, and different estrogenic components, ACRMs, and different other things that is related to the estrogen. Now coming to the progesterone part. So already we have seen in the first part of the menstrual cycle, the estrogen is the predominant hormone, and in the latter part, progesterone is the predominant hormone. So progesterone is a steroidal compound. There are usually synthetic, all the compounds comes under the broad heading of the progestins, okay, progestins. And progesterone is a 21 carbon steroidal hormone, which is the natural progestin. Natural progestin is known as the progesterone, which is synthesized from the cholesterol, which is a steroidal hormone, which is synthesized mainly in the corpus luteum, and then if the pregnancy happens, the placenta, from the placenta progesterone is secreted. And after the estrogen primed endometrium is basically changed to its secretory pattern by means of the progesterone hormone predominance. And at the end of the menstrual cycle, the progesterone level drops and then the menstruation happens. And if there is pregnancy, the corpus luteum continues, and from this corpus luteum progesterone is secreted, and after that from the placenta and from the blastocyst the progesterone is secreted, and this progesterone main function is to keep the blastocyst as it is. So these are the substances which convert the estrogen primed proliferative endometrium to secretory one and maintain pregnancy in animals spread after conception. So natural progestin, what I have discussed, which is a 21 carbon steroidal hormone secreted from the corpus luteum in the range of 10 to 20 milligram per day. Progesterone is secreted in minute amounts in the males also, approximately 5 milligram per day. Synthetic progestins are the synthetic compounds like that of the progesterone. So there are different types of synthetic compounds which have high oral activity, because the progesterone, which is a natural hormone, that is basically degraded in the stomach. So if we have to give the natural progesterone, it is to be given by the intramuscular or intravenous route. But the synthetic progesterones are made in such a way so that the oral bioavailability will be more. And these progestational compounds or the progestins, different types of the progestins, not only have some steroidal activity, but also have in different gradation anti-ovulatory effect, and some have different types of the anti-estrogenic, anti-steroidal, different types of the effects are also there. So there are different terms which we can dictate about the progesterone, like progestins, progestational agents, progestagens, progestogens, gestagens, gestogens, all these are similar. That's why, because these different terms can come. So the natural progesterone, apart from the natural progesterone, there are different series of the synthetic progestational compounds like pregnant, estrone and gonan series. So there are some side chain changes, as well as some carbon, what are the number of the carbons in the compound that dictates in which group it ultimately falls. Like 17 acetoxy progesterone derivatives falls under the pregnant series, 19 not testosterone derivatives falls in the estrone series, and some newer compounds like not gestrel and related, they falls in the gonan series. So estrone, pregnant and gonan series are the different series according to their chemical compound and chemical modifications of the original progestation, which is the natural progestin. So this is the classification of the progestin. The same thing you can see the C21 progestin. This is the natural progestin, progesterone, and these also comes under the pregnant groups, and there are newer synthetic progestins also, like medroxyprogesterone acetate, very commonly used, megestrol acetate and cyproterone acetate. All these are used in different cases. 19 not testosterone compounds that can be divided again estrogens and gonans, like non-ethindrone acetate, ethynadiol, linesterol, non-ethynadrel. So these are the different estrone series progestins. And gonan series progestin like not-gestrel, levonorgestrel, not-gestimate, disogestrel, gestodent. And some spironolactone-like compounds are also there, which are also acts as a progestin, like drospirenone. So these are the different types of the progestins, and this can be used in different combinations with the estrogen, most commonly in the hormone replacement therapy, and another most common indication is the oral contraceptive pills. Okay, we will come to this. So the medroxyprogesterone acetate and megestrol acetate are C21 steroids in the pregnant family with selective activity very similar to that of progesterone itself, like that of the natural progestin itself, the action of medroxyprogesterone acetate and megestrol. Medroxyprogesterone acetate and oral micronized progesterone are widely used with estrogen for hormone replacement therapy or menopausal hormone therapy. Already we have discussed about the hormone replacement therapy in the estrogen class. What happens? Already we have seen that there are some adverse effects of the hormone replacement therapy, particularly when we are using the estrogen, only estrogen, or in high dose of the estrogen. So if we are combining this with progesterone, the adverse effect of the estrogen can be diminished a little bit. Okay, that is for example, endometrial carcinoma, that can be decreased, the incidence can be decreased if we combine the estrogen as well as the progesterone. Depomedroxyprogesterone acetate is also there, that can be used as a long-acting injectable contraceptive. We will come to this. 19 not testosterone derivatives are known as the estrogens, used as progestins mainly in the oral contraceptive pills. So there are different types of the estrogen derivatives that are used as a combination with the estrogen in oral contraceptive pills. The gonans are another family of the 19 not testosterone compounds containing an ethyl substitution rather than methyl. At the 13th position, they have diminished androgenic activity related to the estrogens. So what happens? All these progestational compounds have some amount of the androgenic activity also. So some have more androgenic activity, some have less androgenic activity, some have more anti-ovulatory activity, some have less activity. So accordingly, according to the indications for which disease or for which indication we are using, so the progestational compounds are usually chosen. For example, if we use is as part of a oral contraceptive, so we need more anti-ovulatory effect, for example. So if it is needed, if it is used in some dysmenorrhea or dysfunctional uterine bleeding treatment, so we need some agent that have more anti-androgenic actions like this. So these two classes of the 19 not testosterone derivatives as the progestational compounds of most oral and some long-acting injectable contraceptives. So progestation mainly used as a part of the contraceptive, as a part of the menopausal hormone therapy. So you can see, so details is not required. This is for your impression that all these progestational compounds have some amount of some estrogenic activity, or some progestational activity, or some androgenic activity. So some acts as anti-androgen, some acts as partial androgen, some have more estrogenic activity in addition to their progestational activity, some are less. So accordingly, the different generations are chosen. For example, the last generations, the newer ones are very less. You can see androgenic activity and estrogenic activity, mostly they have progestational activity. The third ones, they have more progestational activity with some amount of the androgenic and some amount of the estrogenic activity, and the older ones have more estrogenic activity as well as androgenic activity in addition to their progestational activity. So ultimately differs to compound. So their physiological and pharmacological actions, mainly their actions are neuroendocrine. So progesterone produced in the luteal phase of the cycle decreases the frequency of the gonadotropin releasing hormone pulses. So when the progesterone ultimately released, so LH and FSH pulses are decreased according to the feedback mechanism. This progesterone mediated decrease in GnRH pulse frequency is critical for suppressing gonadotropin release and resetting the hypothalamic pituitary gonadal axis to transition from the luteal back to the follicular phase. So ultimately the cycle continues. So when the progesterone ultimately secreted, that decreases the GnRH release, ultimately the LH and FSH pulse is decreased, so again it goes into the follicular phase. GnRH suppression is the major mechanism of action of progestin containing contraceptives also. So the contraceptives main action, if there is progesterone, is the suppression of the gonadotropin releasing hormone. Reproductive tract, in the reproductive tract, it decreases the estrogen driven endometrial proliferation. So ultimately it changes the histology of the endometrium from the proliferative to the secretory stage. The abrupt decline in progesterone at the end of the cycle is the main determinant of the onset of the menstruation. So at the end of the menstrual cycle, there is abrupt decrease of the progesterone and ultimately menstruation happens. So if there is pregnancy, if the ovum is fertilized, that is released in the mid-cycle, so the progesterone will continue to be secreted, and this continue ultimately supports the blastocyst or the fertilization. Okay. So if there is no pregnancy, ultimately the progesterone level drops at the end of the menstrual cycle and then menstruation happens. And if the ovum that is released, that is fertilized with the sperm and there is pregnancy, so the corpus luteum remains and it remains to be secreted the progesterone, and this progesterone ultimately saves the fetus. So if there is no progesterone, there will be menstruation and there will be no fetus. So progesterone is basically helps in continuing the pregnancy. It influences the endocervical glands. Abundant watery secretion of the estrogen stimulated structure is tends to a scant viscid material. So what happens? This progesterone makes the endometrium, cervix as well as the associated areas in such a way so that there will be no dual pregnancy. That is, there will be no another fertilization. That means it becomes the watery secretion becomes more viscid, so that there will be less chances of the further fertilization if there is already fertilization taken place. So this is very important for the maintenance of pregnancy, and progesterone suppresses menstruation and uterine contractility. Already we have discussed. So already we have discussed about this. So you can see this is abrupt decrease of the progesterone at the end of the cycle so that the menstruation starts. Metabolic effects, it increases the basal insulin levels. Rise in insulin after carbohydrate ingestion does not normally alter the glucose tolerance. Glucose tolerance normally altered by the estrogen but not by the progesterone. Stimulate lipoprotein lipase activity, enhances fat deposition. Progesterone and analogs like medroxyprogesterone acetate increase LDL to some extent, diminish the effects of the aldosterone in the renal tubule and cause a decrease in sodium reabsorption, and ultimately this increase the mineralocortical secretion from the adrenal cortex. So these are some minor changes in the different endocrine and metabolic sectors. And there are progesterone receptors. Progesterone receptors are present in the gonads, in the breast and in the CNS. Here the progesterone receptor, like that of the estrogen, there are progesterone receptor A and B is there. This is also a nuclear receptor, and like that of the estrogen, when there is the progesterone comes, it attaches with the progesterone receptor, there will be dimerization of the receptor, and then after post receptor modifications take place and this different transcriptional events happens. Therapeutic use, already we have seen hormone replacement therapy. Mainly progesterone that lacks the androgenic activity is preferred. So progesterone with minimal androgenic activity is preferred for the combination with the estrogen for hormone replacement therapy, also known as the menopausal hormone therapy, and given with estrogen basically in cyclic manner to counteract the risks of endometrial carcinoma due to estrogen. Already we have discussed. So hormone replacement therapy we have discussed in the previous class. So there are some pros and cons of the hormone replacement therapy, in which females is to be given, in which if there is some contraindication it should not be given. Like this, in younger women it is to be preferred, but in the older it should not be preferred. It should be preferred in the peripartum period but not very long after having the menopause. So these are the different indications. Hormonal contraceptive we will discuss after this. Treatment of the dysfunctional uterine bleeding. So uterine bleeding becomes dysfunctional. In those cases usually the combinations of the estrogen and progesterone is also given. It is often associated with anovular cycles. Anovular cycle means cycle is continuing but ovulation is not happening. Particularly it is associated with infertility. Okay. So in those cases we need this continued estrogenic action on endometrium without progesterone induction and withdrawal, resulting in incomplete slowing leads to irregular, often profuse bleeding. Given along with cyclic treatment of estrogen regularize the menstrual flow. So if the menstruation is not regular, if there is dysfunctional uterine bleeding, usually the combination of the estrogen and progesterone is given to regularize the cycle. So this is another indication. Endometriosis. Endometriosis is a disease, presence of the endometrium at ectopic sites. So in those sites where the endometrium should not be there. So here is also there may be infertility, there may be more bleeding. Endometriosis, dysmenorrhea, painful pelvic swelling, infertility, all this can happen due to endometriosis, which is a disease. Here is also the treatment is the combination of estrogen and progesterone is usually given. It ultimately causes the atrophy and regression of the ectopic masses, ectopic endometrium. Premenstrual tension and premenstrual stress, this may happen with headache, irritability, fluid retention, breast tenderness, observed few days before menstruation in some of the cases. Here also in severe cases we have to suppress the ovulation by cyclic treatment of the estrogen and progesterone, and it is very effective. So for premenstrual tension or premenstrual stress, dysfunctional uterine bleeding, endometriosis, apart from this endometrial carcinoma, in some cases it is progesterone. Threatened or habitual abortions, in the first trimester, pure progesterone without estrogenic or androgenic activity can be given. Threatened abortion or habitual abortion. So, if there is any history of the abortions multiple times the patient becomes pregnant and there is abortion. So, there may be some pathology is behind there, and it is to be corrected with the progesterone. Premature labor and infertility, luteal support in luteal dysfunction cases. Again, this all happens in case of the infertility, luteal dysfunction, that is the luteal phase of the cycle is dysfunctional. That's why the progesterone is not acting as it is, and hence pregnancy is not occurring. So, infertility, in those cases also premature labor, we have to use the progesterone. So, these all are the indications of the progesterone. Okay. Now coming to the adverse effects, some breast engorgement, fever, headache, fluid retention, depression, irritability, acne. Acne happens because there are some androgenic actions, and acne happens due to the androgenic actions of the progesterone. Diabetes, again some glucose intolerance happens with estrogen or progesterone, so diabetes can be precipitated. Decreased libido, irregular menstrual cycle. For regularization of the menstrual cycle, progesterone is given, but irrespective of this, irregular menstrual cycle can happen. Thromboembolism, atherogenesis, masculinization, congenital abnormalities, all this can happen, and long-term risks of the breast cancer is there. Breast cancer is there with estrogen also, with the menopausal hormone therapy. It is always there. And now coming to the antiprogestin, antiprogestational agent. The most common is the mifepristone, very important, mifepristone. So it is a derivative of the 19-norprogestin, norethinerone, containing a dimethyl aminophenol substituent at the 11th position, that is slightly changed. It effectively competes with both progesterone and glucocorticoids, but for binding to the respective receptors. That is, this mifepristone is both anti-glucocorticoid as well as the anti-progesterone. Initially thought to be a pure antiprogestin agent, but it is now considered to be progesterone receptor modulator. How? Why? Because it has been seen that when there is no progesterone, only mifepristone is given, it basically acts as a partial agonist. That is, it causes the agonism of the progesterone receptor very minutely. So, like partial agonist. But when progesterone is already there, it is given, it acts as an antagonist. Okay, that's why it is known as the progesterone receptor modulator rather than pure antiprogesterone. Okay. Due to its context dependent activity, this is known as the context dependent activity, like that of the already we have seen in the ACRM. So, acts primarily as a competitive receptor antagonist for both progesterone receptors, although it may have some agonist activity, mainly partial agonist in certain contexts. Already I have told about the context. So, pharmacological actions, when administered in the early stages of the pregnancy, mifepristone causes decidual breakdown by blockade of the uterine progesterone receptors. So, progesterone already we have seen that is needed for the continuation of the pregnancy. So, when this mifepristone is given, that blocks the progesterone receptors, so progesterone cannot act. So, the deciduum that is already formed around the blastocyst, that breaks down. Okay. So, this leads to the detachment of the blastocyst. So, blastocyst becomes detached, which decreases the human chorionic gonadotropin secretion. So, whenever the blastocyst is formed, from this the human chorionic gonadotropin is secreted, and this human chorionic gonadotropin ultimately comes to the maternal blood, and that leads to the more secretion of the estrogen as well as the progesterone, and ultimately that causes the continuation of the pregnancy. So, this HCG production also falls, blastocyst becomes detached. This in turn causes a decrease in progesterone secretion from the corpus luteum. So, progesterone is not secreted from the corpus luteum, that is very important for the continuation of pregnancy, and ultimately this further accentuates the decidual breakdown. So, decreased endogenous progesterone So progesterone becomes decreased due to the blockade of the progesterone receptors by means of the mifepristone, as well as the blockade of the progesterone receptors in the uterus also increases the uterine prostaglandin levels. So prostaglandin level is also increased, and that sensitizes the myometrium to their contractile actions. So the myometrial contraction or uterine contraction becomes more. When the uterine contraction becomes more, that further facilitates the detachment and removal of the blastocyst. So it also causes the cervical softening, which facilitates expulsion of the detached blastocyst. So all this leads to detachment and ultimately expulsion of the blastocyst. So it can also delay or prevent ovulation depending on the timing and manner of the administration. So not only it blocks the progesterone receptors, cervical ripening, etc., detachment and expulsion of the blastocyst, it also delay or prevents the ovulation also. It also blinds the glucocorticoids and androgen receptors and exerts some anti-glucocorticoid and anti-androgenic actions. So it has some progesterone receptor modulatory actions, mainly antiprogestational, but when there is no progesterone, it may act as a partial agonist to progesterone receptor alpha and beta. It acts as an anti-glucocorticoid hormone, as well as it has some anti-androgenic actions also. Thus, mifepristone blocks the feedback inhibition by cortisol of ACTH secretion from the pituitary and ultimately increases the plasma levels of the corticotrophin and adrenal steroid. So the plasma levels of the adrenal steroid is also increased, corticotrophin is also increased. So ultimately from this, it is clear that mifepristone is mainly used when there is already pregnancy happens, already there is blastocyst, we have to detach and expulsion of the blastocyst. So mifepristone is primarily used as an abortifacient agent. So it is used for the medical termination of pregnancy, that is abortion. So mainly it is used up to the 7 weeks of the pregnancy. 600 milligram as single oral dose causes complete abortion in 60 to 85% of the cases. You can see that this is not 100%, 60 to 85% cases. So when there is pregnancy, if it is given during the initial up to 7 weeks, up to approximately 2 months of the pregnancy, if the mifepristone is given 600 milligram single dose, it has been seen 60 to 85% cases it causes abortion. To improve the success rate, that is to improve this 60 to 85%, current recommendation is to follow it up 48 hours later by a single 400 milligram oral dose of the misoprostol. Okay. This misoprostol causes more uterine contraction. So this achieves greater than 90% success rate and is the accepted non-surgical method of the early first trimester abortion. This is known as the medical termination of the pregnancy or early first trimester abortion. This is done by the main drug is the mifepristone, which is a antiprogestational agent, and usually it is followed up with the misoprostol. It is not effective after 7 weeks. This is very important because later placenta starts secreting enough progesterone, that progesterone. Already in time and again I am saying that progesterone is the main agent that helps in continuation of the pregnancy. But after 7 weeks, it takes over, the placenta takes over the synthesis of the progesterone. So large amount of the progesterone is secreted. So even if we are using the mifepristone, it cannot antagonize the progesterone receptors and the blastocyst cannot be detached and expelled. So after 7 weeks, placenta starts enough progesterone to overcome the antiprogestin effect of the mifepristone. So it can come as a question. So mifepristone is very important as a short note, and why mifepristone is usually used as a abortifacient agent only in the first 7 weeks. Because after the 7 weeks, the placenta takes over for the synthesis of the large amount of the progesterone, and this large amount of the progesterone cannot be counteracted by giving the mifepristone. Postcoital contraceptive, will come to this also. So postcoital, so after the sexual intercourse, usually within the 72 hours, mifepristone can be used as a contraceptive device, an effective method for emergency contraception. Softening of the cervix, it is usually done when there is mifepristone softens and dilates cervix prior to surgical abortion or labor induction. So usually induction of the labor, that is for the delivery, also mifepristone is used because it usually helps in more contraction and ultimately the fetus will come out. For induction of the liver, mainly in case of the intrauterine fetal death, that is within the uterus the fetal death already happens. If it continues, there will be complications. There will be high maternal death also. So we have to expel the dead fetus, and for this also mifepristone is used. Endometriosis, already we have seen this endometriosis also it can be used. Uterine fibroids. Fibroid is a non-malignant tumor and it is also associated with infertility. Here it can be used. Progesterone dependent brain neoplasm like meningioma. In meningioma there are progesterone receptors. So if we are using the mifepristone, that can decrease the size shrinkage of the tumor can happen. Breast cancer, Cushing syndrome as a palliative due to glucocorticoid receptor blocking property may be used for inoperable cases. So Cushing syndrome again happens due to some adrenal tumor, So there are different types of the drugs and mostly the surgical methods are adopted since progesterone have anti-steroid activity, so we can give this for shrinkage. Side effect is of course the abortion failure. That is the problem because it is not 100%, so abortion failure can happen. So ultimately that leads to prolonged bleeding, abdominal cramps, vomiting, diarrhea, anorexia, all can happen. So this is about the mifepristone, very important. Next is the ulipristal. Ulipristal is another derivative of the 19 non-progesterone which functions as a selective progesterone receptor modulator like that of the SERM, selective estrogen receptor modulator. So basically it is a partial agonist at progesterone receptor. It appears to be relatively weak glucocorticoid antagonist. High doses has anti-proliferative effect in the uterus. Its most relevant actions to date involves its capacity to inhibit ovulation. So mainly ulipristal is used as anti-ovulatory agent to inhibit the ovulation. So inhibition of the LH release through the hypothalamus and pituitary, because this LH pulses is needed, LH and FSH burst is needed for ovulation. So if it is blocked, so ovulation will not happen. Inhibition of the LH induced follicular rupture within the ovary, and mainly this ulipristal is also used as an emergency contraceptive. Now coming to the hormonal contraceptive. So the most important usage of this estrogen and progesterone right now is the hormonal contraceptive, because the menopausal hormonal therapy is controversial. Already we have seen this is a very important question. What are the pros and cons of the menopausal hormonal therapy or hormone replacement therapy? Problems with the estrogen and why the progesterone is to be added, etc., etc. So hormonal contraceptive, in India the contraceptive prevalence is still now it is low, less than 50%. 21% of all pregnancies resulting live births are unplanned, and ultimately there are several unmet needs, and that's why that contraceptive awareness is very necessary for all the common people. Okay. So contraception means we are just interrupting. So interception in the birth process at any stage ranging from the ovulation to ovum implantation. So after the ovulation happens, if there is sperm, there is fertilization, and then the implantation happens, and then the blastocyst, and then from the blastocyst HCG is secreted, progesterone takes over. So within this time period, if we are intercepting this, ultimately there will be no pregnancy. So this is known as the contraception. So you can see, you know from this physiology, from this what are the different days, how the blastocyst implantation happens. You just revise this. Okay. So the oral contraceptive pill is more easier to use, and there are different other contraceptives also. We will come to this, injectable contraceptives, etc. Oral contraceptive pills are easier to use, which is taken orally and ultimately prevents the pregnancy. So the most common contraceptive pill, oral contraceptive pill, is the combination oral contraceptive pill, COC. Okay, combination oral OCP, COCP, combination. Combination means combination of the estrogen and progesterone. So the most frequently agents, their theoretical efficacy you can see approximately 99.9%. Combination oral contraceptives are available in many formulations, most commonly monophasic. Apart from this, there are biphasic and triphasic pills. We will come to this. Generally, the contraceptives are used in a 21 days pack. Virtually all preparations, you can see that this is a 28 days pack with 7 tablets are usually placebo or some iron tablets. And there are progesterone-only contraceptive is also there. Progesterone-only contraceptive. Advantage is the problems with the estrogen are very less, because the problems with the estrogen, there is always chances of the thromboembolism, there is always chances of the endometrial carcinoma. These are very less with the progesterone-only pill. But again, the efficacy is also less. Efficacy is less, approximately 90 to 99%. Okay. So combination oral contraceptive pill, estrogen and progesterone. Estrogen most commonly use the ethinyl estradiol. So what happens, there are different research, and accordingly it has been seen that with lower estrogen doses, the adverse effect of the estrogen will be less and the efficacy is also more or less similar to the high dose of the estrogen. It has been seen. Previously, when in the oral contraceptive pill, the estrogen use is approximately 100 microgram. Very high dose of the estrogen is given. Because high dose of the estrogen, obviously the efficacy will be more and more. But it has been seen with different, all types of the adverse effects that is associated with the estrogen. And ultimately, by the different research, it has gradually decreased to 50 microgram and again 35, 30 and even 20 microgram now. So now it has been seen that this 35 microgram to 20 microgram, in this range, if we are using the estrogen, this is known as the low dose pills and it is also equally efficacious to that of the high dose estrogen. It has been seen and that's why the recent combination oral contraceptive pills usually contains this minimal amount of the estrogen, approximately 20 to 35 microgram. And menstrual can also be used, 3-ethyl ester of the ethinyl estradiol. So you can see about the dosage, how the estrogen dosage is gradually diminished in combination oral contraceptive pill. Now normally 20 to 35 microgram estradiol, normally the ethinyl estradiol is used. Progesterone, usually the 19 not testosterone derivatives are used because they have high anti-ovulatory actions. That's why these derivatives are used. Like norethindrone, levonorgestrel 150 microgram, gestodene 75 microgram, disogestrel 150 microgram, non-gestimate 250 microgram, or 17 alpha spironolactone derivatives like drospirenone 3 milligram. So the previous ones and this one, any one, these are combined together. So the combined pills, these may be monophasic, biphasic and triphasic. Monophasic means the same amount of the combination estrogen and progesterone is present throughout all the tablets that is to be taken in the whole menstrual cycle. So each tablet contains a fixed amount of the estrogen and progesterone, most commonly used. Biphasic means each tablet contains a fixed amount of estrogen while the amount of the progesterone increases in the second half of the cycle. So it becomes more physiological. And the triphasic means here the amount of the estrogen may be fixed or variable. So estrogen amount is also variable and the amount of the progesterone increases in 3 equal phases. All these are done to mimic the normal physiological changes of the estrogen and progesterone hormones in the body. That's why. So it has been possible to reduce the amount of the estrogen and progesterone in the newer generation or second generation oral contraceptive pills without compromising efficacy but reducing the side effects and complications. Already we have discussed. So previously high dose of the estrogen is used. Now it has been seen that with very less dose of the estrogen as well as the progesterone also, the efficacy is equal. The third generation pills contain newer progestins like disogestrel with improved profile of action have been introduced in the 1990s. The newer progestins means their antiprogesterone action and anti-ovulatory actions are more and their anti-estrogen actions or other steroidal actions are less. Ethinyl estradiol 30 microgram daily is considered threshold but can be reduced to 20 microgram per day. Already we have seen if a progestin with potent anti-ovulatory action is included. So it has been seen that 30 is usually now the threshold, 35, but it has been further decreased to 20 if we are adding this with a progesterone agent with very high anti-ovulatory action, ultimately that compensates. Like if we are using the newer progesterone like disogestrel, this disogestrel has very high anti-ovulatory effect. So if you are combining this with very low 20 microgram of the ethinyl estradiol, so ethinyl estradiol 20 microgram plus disogestrel, that is equally efficacious to very high dosing of the estrogen and progesterone pills. The progestin is a 19 not testosterone because these are potent anti-ovulatory action, already we have seen. So usually we have to choose those progesterone with a very high anti-ovulatory action. The estrogen content is generally 20 to 50, already we have seen this can be decreased to 30 to 35, ultimately gives good cycle control in the individual woman. So the newer ones which have less than 35 microgram estrogen are known as the low dose pills, low dose combined contraceptive pills. The combined pill is to be taken for 21 consecutive days followed by 7 pill free period, which causes a withdrawal bleed, and during this 7 pill free period usually the withdrawal bleeding happens. Normal cycles of the menstruation usually commences fairly soon after discontinuing the treatment. Triphasic pills, here the changes. So in the three stages, usually the dosing of the estrogen or progesterone can be changed. Otherwise, more or less similar. dosage varies over the course of the cycle. Minimum dosage in the first half of the cycle for contraceptive purposes and maximum dosage given in the latter part of the cycle to prevent breakthrough bleeding. Advantages: the lipid profile is contraceptive efficacy is more or less similar, and lipid profile effect is also less. So you can see the first 6 tablets contain 50 microgram levonorgestrel and 30 microgram ethinyl estradiol, and next 5 tablets 75 microgram levonorgestrel plus 40 microgram ethinyl estradiol, and last 10 tablets high dosing 125 microgram levonorgestrel and 30 microgram ethinyl estradiol. Usually in the package, usually the days are coded, that is day 1, 2, 3, 4, 5, 6 like this. Okay, so this is known as the triphasic pills. So monophasic, biphasic, triphasic pills, usually most commonly the monophasic pills are used, but these are more physiological. Mode of action: how this combined oral contraceptive pills causes the contraception. Estrogen inhibits the secretion of the FSH via negative feedback on the anterior pituitary and thus suppresses development of the ovarian follicle. Already we know it decreases the by negative feedback, it causes development of the ovarian follicle. Progesterone on the other hand inhibits secretion of the LH and thus prevents ovulation. Ovulation is prevented, makes the cervical mucus less suitable for the passage of the sperm. The cervical mucosa becomes more scanty and viscid. Estrogen and progesterone act in concert to alter the endometrium in such a way to discourage the implantation. So basically this acts in the several levels. So acts in the ovulation levels, acts in the implantation levels, etc. They may also interfere with the coordinated contractions of the cervix, uterus and fallopian tubes that facilitate fertilization and implantation. So this coordinated contraction of cervix, uterus and fallopian tubes is needed for the appropriate implantation of the blastocyst, and this is also interfered with by means of this combined oral contraceptive pills. Now there are some common adverse effects of this combined oral contraceptive pill. Weight gain, very common adverse effect. Weight gain can happen owing to fluid retention or an anabolic effect at both. Fluid retention means it has some spironolactone like activity, it also has some steroid like activity and also some anabolic activity like that of the testosterone. That's why androgenic activity. Mild nausea, flushing, dizziness, depression or irritability can happen. Skin changes, acne can happen or an increase in pigmentation. Amenorrhea of variable duration on cessation of the taking the pill. Amenorrhea can happen with continuation of the pills also. Some potential adverse effects, that is, it is controversial and it cannot be seen in all the cases, like some cardiovascular, although rare. The most serious adverse effects in some cardiovascular disease like thromboembolism, although it is less with lower doses of the estrogen. With higher doses, the chances of the thromboembolism is more. Deep vein thrombosis is more, hypertension, myocardial infarction, stroke, etc. and more. But with lower doses, these chances are very less. Carcinogenicity, again it is less, but it may increase the risk of cervical cancer by about 2-fold only in long-term users with HPV infection. That is, if there is already human papilloma virus infection, this human papilloma virus ultimately causes more chances of the cervical cancer. So in those cases, if they are taking the contraceptive pill, that further increases the chance. Abnormal glucose tolerance, weight gain, etc. can happen. Serum lipids, there are some changes in the serum lipids profile like LDL cholesterol can be increased. Progesterone may negate some of the beneficial effects of the estrogen, more or less similar thing. Now coming to the beneficial effects of the combined oral contraceptive pill. They markedly decrease the menstrual symptoms such as the irregular period and intermenstrual bleeding. In fact, for the treatment of the irregular bleeding and intermenstrual bleeding, different types of the dysfunctional bleeding, already we have seen the combination of the estrogen and progesterone are used. Basically, these contraceptive pills are used as a treatment for irregular bleeding. Okay. Iron deficiency anemia and premenstrual tension are reduced. As a benign breast disease, some uterine fibroid, functional cyst of the ovary. So in all these cases, already we have seen the indications of the progesterone. All these are basically used as a combination of the estrogen and progesterone. Usually in the market, the oral contraceptive pills are there. So these oral contraceptive pills are not only used only for contraception, but also used for the treatment of all these conditions. Like if there is premenstrual tension, benign breast disease, uterine fibroids, endometriosis, functional cyst of the ovary, irregular bleeding, irregular menstrual bleeding, intermenstrual bleeding, dysfunctional uterine bleeding, all these cases. There are some non-contraceptive benefits. This is also important, very important. What are the non-contraceptive benefits of the contraceptive pills? So regulation of the cycle with decreased amount of duration, already we have discussed, cycle becomes regular. Helps in prevention and treatment of the iron deficiency anemia. So if there is a very profuse menstrual bleeding, so there are more chances of the iron deficiency anemia. So we can use this. Decreased risk of epithelial ovarian tumors, decreased incidence of the functional ovarian cyst, decreased risk of ectopic pregnancy, very dangerous ectopic pregnancy, decreased risk of developing pelvic inflammatory disease, decreased risk of endometrial cancer and spasmodic dysmania and premenstrual syndrome, decreased risk of benign breast lesions. So this is very important. All these problems are decreased when using continuously the contraceptive pill. May protect from colorectal cancer, may decrease the incidence of the fibroid, improvement of the rheumatoid arthritis, treatment of the dysfunctional uterine bleeding, already we have discussed, treatment of endometriosis, postponing of the menstruation of social causes, treatment of hirsutism, anti-androgenic progesterone like drospirenone can be used. So non-contraceptive benefits of the contraceptives. This is a very important question. Okay. So all these are the non-contraceptive benefits of the contraceptive. And this is also very important question. Some absolute and relative contraindications of the contraceptive. Absolute contraindications, less than 6 months postpartum if breastfeeding, if the woman is breastfeeding. Smoker over the age of 35 with greater than equal to 15 cigarettes per day, very high smoking. Hypertension, systolic greater than equal to 160 and diastolic greater than equal to 100, because this very highly increases the chances of the thromboembolism, myocardial infarction and stroke. Current or past history of venous thromboembolism, ischemic heart disease, history of cerebrovascular accident means stroke, complicated valvular heart disease, migraine headache with focal neurological symptoms, breast cancer, diabetes with retinopathy, nephropathy or neuropathy, that is complicated diabetes, severe cirrhosis in the liver tumor like adenoma or hepatoma. So these are the absolute contraindications of the contraceptive. So when you are prescribing the contraceptive to any woman, so you have to ask about these contraindications whether it is present or not. These are relative contraindications. Relative means we have to weigh the pros and cons, and accordingly we can choose some patients to give and some patients not to give. So smoker, but the cigarette count you can see less than 15 cigarettes. Hypertension, but you can see the systolic 142, 159. This is higher, greater than 160 and greater than 100, absolute. And relative is the 142, 159, 92, 99. Currently symptomatic gallbladder disease, mild cirrhosis, history of combined oral contraceptive pill related cholestasis, undiagnosed vaginal bleeding, uterine leiomyoma, this is another tumor. This may enlarge with estrogenic preparations, progesterone-only pills can be used. Use of medications that may interfere with combined oral contraceptive metabolism. Okay, so these are the relative contraindications of the combined oral contraceptive pill. Now coming to the progesterone-only pill, that means this pill contains only the progesterone but no estrogen. These drugs usually used are the norethistérone, levonorgestrel or ethinydiol. The pill is taken daily without interruption, so there will be no 7 days gap when you are using the progesterone-only pills. The mode of action is primarily on the cervical mucus, which is made inhospitable to sperms. That is, the mucus secretion becomes scanty, more viscid, so that there becomes inhospitable to sperm. The progesterone probably hinders the implantation through its effect on the endometrium and on the motility and secretions of the fallopian tube. So in multiple pronged, it ultimately helps in contraception. So potential beneficial and unwanted effects of these progesterone-only pills. They are suitable alternative, suitable for women whose blood pressure increases unacceptably during treatment with estrogen. So in those cases where there is some contraindications of the combined oral contraceptive pill, we can use the progesterone-only pill. The contraceptive effect is less reliable, efficacy is lesser. Missing a dose may result in conception, that is the problem. Disturbance of menstruation, irregular bleeding is very common. Aside from the bleeding irregularities, headache is the most commonly reported untoward effect of the dipomethylhydroxyprogesterone acetate. Mood changes, weight gain can happen. There may be decrease in HDL level, increase in LDL level. However, these preparations may be attractive for nursing mothers because they do not decrease lactation as do products containing estrogen. So basically progesterone-only pills are mainly used in nursing mothers, that is breastfeeding mothers. Usually the progesterone-only pills are used. Centroman, also known as the Soheli. this is ormeloxifene. Already we have seen the ormeloxifene is a selective estrogen receptor modulator. Already we have seen after the tamoxifen, raloxifene, I have shown the ormeloxifene. So this is a research product of our country, India. CDRI Lucknow, it has been discovered. That's why this is very important. This is a non-steroidal compound. Potent anti-estrogenic and weakly estrogenic some actions are there. Prevent implantation of the fertilized ovum. Orally 30 milligram twice weekly for first 3 months, then once a week. This Synchroman is usually used in the national program in some of the states. It should be avoided in PCOD, liver, kidney disease. So basically, this is a selective estrogen receptor modulator. Remember the name. Pharmacokinetics of the OCP. These oral contraceptive pills are basically metabolized by the cytochrome P450 enzymes. That's why there are some drugs that ultimately induces or inhibits the cytochrome P450 enzyme. So there will be some drug-drug interactions. That is the problem. Contraceptive failure may occur if the following drugs are used concurrently. Contraceptive failure means if these drugs are used, ultimately there will be induction of the enzymes. So the contraceptive pills becomes more metabolized. So contraceptive failure, conception may happen. Like enzyme inducer like phenytoin, phenobarbital, primidone, carbamazepine, rifampicin, ritonavir. Suppression of the intestinal microflora like tetracycline, ampicillin. We will discuss about this in the antibiotic chapter. So in these cases there may be some contraceptive failure. So next coming to the emergency pill or post-coital pill, this is also important for examination. Already we have seen in the progesterone chapter. So these are for use in a woman not taking any contraceptive who has sexual intercourse risking unwanted pregnancy. So for emergency usage, the most commonly used and standard regimen is the levonorgestrel. This is known as the UJPE method. Levonorgestrel 0.75 milligram, 2 doses 12 hours apart, or 1.5 milligram single dose taken as soon as possible, but before 72 hours of the unprotected intercourse. So after 72 hours, this emergency contraceptive pill will not act. It will act only within the 72 hours of the unprotected sexual intercourse. 2 to 3 times more effective and better tolerated than the earlier method. Earlier method is the UJPE method, which use levonorgestrel 0.5 milligram plus ethinylestradiol 0.1 milligram, 2 doses at 12-hour interval within 72 hours of exposure. Recently, already we have seen the ulipristal. Ulipristal has also been approved for the emergency contraception. So emergency contraception, you have to write about the levonorgestrel. This combination of the levonorgestrel, lower dose plus ethinylestradiol, and the ulipristal, which is a selective progesterone receptor modulator. All this has to be used within the 72 hours, and usually the 2 doses are needed. Next, coming to the injectable hormonal contraceptives. So the oral ones is the most common ones, but some injectable hormonal contraceptives are also there. The most common are 2. One is the dipomedroxyprogesterone acetate, another is the norethindrone enanthate. These are more common in the Western world, but in our country injectables are lesser used now. The most important drawback is the complete disruption of the menstrual bleeding pattern, a total amenorrhea. That is the problem that may happen with dipomedroxyprogesterone acetate. It is not suitable for adolescent girls and lactating mothers. Return of the fertility may take 6 to 30 months. So that is the problem. With oral contraceptive pills, usually after stoppage, the return of the fertility is usually quick. But with injectable hormonal contraceptives, the return of the fertility is more. A long duration is needed. Weight gain and headache may occur. So remember the name dipomedroxyprogesterone acetate and norethindrone enanthate. These 2 are the injectable hormonal contraceptives. So hormonal contraceptives, discontinuation of the all oral contraceptive result in return of the fertility within usually 1 to 2 months. So stoppage within 1 to 2 months, return of the fertility happens. There may be even rebound increase in fertility. So chances of the multiple pregnancy are more if conception occurs within 2 to 3 cycles of this. With injectable preparation, return of the fertility is delayed. Already we have seen. If a woman on combined pill misses to take a tablet, she should be advised to take 2 tablets the next day and continue as usual. If more than 2 tablets are missed, then the course should be interrupted. And an alternative method of the contraception used, the next course started on the 5th day of the menstruation. This must to be told to the patient who are using the contraceptive pills that if you are missing 1 pill, you have to take it in the next day 2 pills. But if you are missing 2 pills at a time, again it has to be discontinued. Again for the next menstrual cycle, it is to be continued. Implants, there are some implants, okay. These are the drug delivery systems. When we have read in the drug delivery system, there are implants from which there are slow release of the drugs. So biodegradable polymeric matrices and non-biodegradable rubber membranes. This can be used as a contraceptive device. They release, steroid is released slowly over a period of the 1 to 5 years. The example is the Norplant and Progesterone. Remember the name Norplant and Progesterone. Norplant is a set of 6 capsules, each containing 36 mg of levonorgestrel. That is total 216 mg for subcutaneous implantation. Works for up to 5 years. So this is the Norplant, levonorgestrel. And another is the Progesterone, which is an impregnated intrauterine insert. It contains 52 mg of the levonorgestrel, which primarily acts on the endometrium. Again, it is usually effective for the 5 years, but the efficacy is lower. So Norplant and Progesterone are the implants. So we have seen the injectable hormonal contraceptives, and this is the implants as hormonal contraceptive. So you can see this is the Implanon. This is a non-biodegradable single rod implant for subdermal use. Usually it is used subdermally. 3 years implant, 68 mg etonorgestrel, the newer ones are used, highly effective. Endogenous estrogen is present, bones are protected, easier removal than Norplant and requires provider training. Implanon, these are the newer ones. Implanon. There are some vaginal contraceptive ring or Nuva ring. Okay. So basically this contains etonorgestrel. 0.12 mg per day etonorgestrel is released, which is basically a metabolite of the disogestrel, and 15 microgram per day of the ethinyl estradiol. So it is a combination of the ethinyl estradiol and the etonorgestrel. Usually again it is to be given 3 weeks in and 1 week ring free period, like that of the oral contraceptive pill. So the 3 weeks it is to be inserted and 1 week without ring. Less breakthrough bleeding than the oral contraceptives. Advantage is rapid return to ovulation, lower doses of the hormones, ease and convenience, and improved cycle control. And contraindications are like that of the oral contraceptive. So you can see that this is a different drug delivery devices, drug delivery systems. So newer drug delivery systems. So you have read in the drug delivery systems in the first chapter. Newer drug delivery systems like vaginal contraceptive ring or Nuva ring. There are also transdermal delivery system. Again, you have read about the transdermal delivery system in the first chapter. So Nestoron. Nestoron is a newer progestin which is available as a cream as well as the transdermal patch. The patches are used like pills. Again, the 3 weeks on and 1 week off, usually given in the shoulder area. So again, the ring or the transdermal patch or all to be used as a 3 weeks on and 1 week off. This is the mode. Okay. So transdermal delivery system, Nestoron. Remember the name Nestoron is used as a transdermal contraceptive. Lastly, coming to the male contraceptives, the only way to suppress the male fertility by drugs is to inhibit the spermatogenesis. But the problem is here, because the spermatogenesis takes approximately 64 days. So if you are blocking this or if you are again withdrawing this, so there will be problem. So complete suppression of the spermatogenesis is relatively difficult without affecting the other tissues. So when it is used, it approximately causes the problems in the other tissues also. Takes approximately 64 days spermatogenesis. So drug which even completely inhibited the spermatogenesis will take a long latent period to produce the infertility. Accordingly, return of the fertility will also be slow. So that is the problem. Gonadotropin suppression inhibits testosterone secretion as well, resulting in loss of libido and impotence. So impotency can come and risks of adverse effects are also there. So these are the drugs mainly in the research purposes it has been used. Some anti-androgens and androgenic drugs, estrogen and progesterone again combination has been used for research purposes. Superactive gonadotropin releasing hormone analogs, some cytotoxic drugs like cadmium, nitrofurans, indoles, and gossipol is newer ones which have shown some promise. So it is a non-steroidal compound obtained from the cotton seed. It is effective orally, causes suppression of the spermatogenesis and reduces the total sperm count. Fertility is restored several months after discontinuation. However, about 10% men remain the oligospermic. So that is the problem with the male contraceptive. So thank you. So this is all about the female sex hormones as well as the contraceptives. So within this, already I have said, again I am telling, within the contraceptives is very important chapter. Some questions will obviously come in the theory as well as the viva. So what is the combined oral contraceptive pill? Why the estrogen progesterone are given together? What are the different types of the combined oral contraceptive pill? That is monophasic, biphasic, triphasic. Why these phases are there? How the contraceptive pill acts in contraception. So mechanism of action of the contraceptive pill. Progesterone-only pill can come as a short note. What is the mechanism of action as well as the adverse effects and the problems with the progesterone-only pills, that it is not too efficacious. Then coming to the what are the non-contraceptive benefits of the contraceptives, very important questions, as well as the what are the absolute contraindication and relative contraindication of the contraceptives, and what are the other methods of the contraceptives, like what are some transdermal devices, some rings, some injectable, what are the injectable contraceptives, what are the implants, all this can come, okay. And what are the indications, already I've said about the indications of the estrogen, progesterone, menopausal hormonal therapy or hormone replacement therapy, also very important. What are the problems with the hormone replacement therapy? Why again the combination of the estrogen progesterone is given? All this can come. And apart from this, selective estrogen receptor modulator, very important, and antiprogestin mifepristone as well as the clomiphene citrate. These three are very important, can come as a short note also.